Dear audience, welcome everyone. First, I would like to introduce myself. I am Benjámin Skribek from the Department of Oncoradiology. We have a vision that minimally invasive therapies will be readily available solutions in the treatment in multiple diseases. We would like to simplify the treatment of patients suffering from various diseases, especially tumors. Our aim is to launch novel human effective and safe therapies in Hungary. You can see my two ongoing projects. The first is investigating the efficacy of minimally invasive interventions versus laparoscopy in the treatment of benign adrenal gland tumors. The prevalence of these adrenal tumors is between 1 and 4% in the general adult population. Most of these tumors are adenomas, and they have a hormone-producing possibility. And this hormone-producing possibility has many clinical consequences. For example, high blood pressure, hypokalemia, constipation, diabetes, and other organ failures. The gold standard treatment is laparoscopic adrenalectomy. But laparoscopic adrenalectomy not always applicable. There are many cases, for example, the tumor size, the anemia of the patient, the hormone-producing possibilities, sometimes cannot get applied laparoscopy. Laparoscopy has another disadvantage. For example, it has relatively prolonged postoperative hospitalization time. It is usually 3 or 4 days. Nowadays, we have many new procedures, techniques, for example, embolization techniques, mechanical, chemical, and thermoablation procedures, which can replace laparoscopy. These procedures has reduced interventional duration, it has decreased perioperative blood loss, and has less postoperative hospitalization, which is usually 1 or 2 days, and has also faster recovery after the procedure. Our aim is to compare laparoscopic adrenalectomy and minimally invasive interventions in the treatment of benign adrenal gland tumors. Our clinical question that are minimally invasive interventions safer and more effective therapeutic options for patients with benign adrenal gland tumors than laparoscopic adrenalectomy. We use the PICO framework. We compared the minimally invasive interventions versus laparoscopy in the treatment of these benign adrenal gland tumors. We have primary and secondary outcomes also. The primary outcomes are the complication rate, the success rate, which is a biochemical success rate, and we have secondary outcomes also. For example, operation time, postoperative recovery, perioperative blood loss, and postoperative pain treatment. Our hypothesis that minimally invasive interventions are safer and more effective therapeutic options than laparoscopic adrenalectomy. We used during our systematic search the following search key, which has 3 main domains, and 5 databases were conducted. You can see my flow chart of selection, and after the selection process we had 5 eligible articles. Next, I would like to summarize a few forest plots. Which the first one is the complication rate we analyzed. You can see that we compared laparoscopic adrenalectomy with ablation procedures, and these outcomes, it's really important to know the results of them, because we should choose before the operation, before the treatment, which therapeutic option to choose. You can see that no significant difference between the 2 groups in complication rates, but the main complications during procedures is the hypertensive crisis. You can see that it has an 8.13 odds ratio in favor of ablation. So if we consider these complications, we suggest that laparoscopic adrenalectomy is a safer therapeutic option for the patients who has benign adrenal gland tumors. Our next forest plot is the resolution of hypertension. You can see that the resolution of hypertension is more common after laparoscopy. So if we analyze these results, we can say that the laparoscopic procedures are more effective therapeutic options. Next, secondary outcome is the operation time. We can see that ablation procedures are shorter techniques than laparoscopic. The calculation was in mean difference, which is 75 minutes less than laparoscopy. Length of hospital stay. The length of hospital stay after ablation is shorter, 1 or 2 days after the ablation than after laparoscopy. We have main table. I would emphasize that we have only retrospective studies, and in our included studies, the main type of ablation procedures are radiofrequency ablation, and we have only one article which focuses on ethanol ablation. Our meta-analysis has strengths and limitations also. For example, the included studies have similar eligibility criteria, and they focuses ethanol and radiofrequency ablations also. And we use only comparative articles in our analysis. But we have limitations that these included studies, all of them are retrospective studies, and they are working with low number of patients and focuses only aldosterone-producing adenomas. Our conclusion that ablation procedures, including ethanol and radiofrequency ablation, have higher risk of hypertensive crises during the procedures and have lower biochemical effectiveness. But they are associated with shorter operation time and hospital stay with decreased perioperative blood loss. We have implications for practice such as laparoscopic adrenalectomy is the most appropriate procedure in these days, and this procedure remains the gold standard therapy. But there are many cases when ablation can be an alternative therapeutic option. But to confirm our results, we need more comparative studies, mainly more RCTs. You can see my manuscript status. I have finished all the parts, just we have to correct the mistakes, and we would like to send to internal review on March. Our first journal is the Investigative Radiology Journal. My second topic is investigating the efficacy and safety of minimally invasive interventions in the treatment of low intermediate risk localized prostate cancer. Prostate cancer is the second most commonly diagnosed cancer in adult men population, and they are usually asymptomatic tumors. The first line treatments, radical prostatectomy and radiation therapy. But these therapies have many complications, for example, erectile dysfunction, total and stress, urinary incontinence, rectal injury, wound infection, and anastomotic stenosis. There are also many minimally invasive procedures which can replace these first-line treatments. For example, thermoablation, HIFU, irreversible electroporation, ultrasound ablation, etc. Our aim is to find the most appropriate interventional procedure for the treatment of low intermediate risk prostate cancer. Our clinical question that which interventional procedure is the safest, most effective therapeutic option for patients with low-mid localized prostate tumors. Our outcomes complicate rates and progression-free survival. Our hypothesis, by comparing different intervention procedures, we can determine which is the safest and most effective therapy in the treatment of low intermediate risk localized prostate tumors. Here is my preliminary research. We found almost 42,000 articles, and only 8 meta-analyses which we would like to extend and write a network meta-analysis. It is my summary of my ongoing projects, and I would like to thank you for your attention, and I would like to close my speaking with Benjamin Franklin words: tell me and I forget, teach me and I remember, involve me and I will learn. Thank you very much.
How do you select the optimal patients for ablation in your following your first meta? What is your recommendation?
There is no general recommendation, but we selected...
What is your recommendation upon your meta-analysis?
It is the size of the tumor. We would suggest that under 4 centimeter diameter, the ablation procedure is really effective.
Only the size?
Is the main possibility, but the hypertension can be an effective.
Might be contraindicate your decision.
Yes,
in hypertensive patients, you consider ablation.
Yes.
And if the patient is not hypertensive, but the adenoma is under 4 centimeters, you can ablate it.
Yeah, if the patient...
I think it's a simple method. Thank you. It's a good advice, I think.
Thanks. Yeah, thank you for the presentation. I would like to ask you a question about your first project. So in figure 2 and 3, I think there were results where they were significant. In the first case, it was an odds ratio significantly different from 1, but the confidence interval ran from around 1.1 to like 60. And the third figure, the mean difference again was significant, but the confidence interval was like from minus 6 minutes to minus 100 and something. So what do you think these wide confidence intervals have in relation to the clinical implications of your findings?
Yeah, you mentioned the operation time. It has a huge heterogeneity because the included studies starts the procedure from the beginning, from the preparations, and it finishes with the afterworks. But many studies only count the exact procedural time. So it is the reason of heterogeneity. But I can say your question that in terms of operation time, that the lower operation times help the recovery, and it causes faster recovery after the procedure.